All right, you should be good to go, Tyler.
Okay, thanks, Caleb. All right, welcome everybody. Thank you for joining us today. My name is Tyler Peterson. I'm a current second-year medical student here at Wayne State, and I'm also the president of our school's chapter of the Benjamin Rush Institute. So the BRI's mission is to preserve the doctor-patient relationship, believing that it's fundamental to good healthcare policy and practice. And one of the ways it does is by educating medical students on alternative models of care, like direct primary care. And that's a great segue to our speaker today, Dr. Paul Thomas. Dr. Thomas himself is a graduate of the Wayne State Medical School in Detroit, and he's currently a clinical assistant professor. He's a family medicine physician and founder of Plum Health DPC, which is a direct primary care practice that delivers cost-effective primary care services to Detroit's populations and beyond. He's also the author of 2 books, both of which are available on Amazon. The first being Direct Primary Care, The Cure for Our Broken Healthcare System, and the second being titled Startup DPC, How to Start and Grow Your Direct Primary Care Practice. So Dr. Thomas will be speaking to us today on many different aspects regarding direct primary care. And after his presentation, you'll have the opportunity to ask him any and all questions regarding DPC. So without further ado, I am very pleased to introduce Dr. Thomas. Dr. Thomas, thanks for joining us today.
Hey, thanks for the introduction, Tyler. I appreciate it. Thanks for having me here today. And I'm happy to talk with all of you. Direct primary care is something I'm obviously passionate about. And we're just going to get right into this presentation, and feel free to ask any questions along the way. I think Tyler and his team are going to kind of aggregate those questions, and we'll get to them at the end. So anything you want to ask, put in the chat box. We'll get to it. All right, so we're going to start by talking about direct primary care. Let's see if I can get this slideshow to show up here. So this is something I put together for the Michigan Academy of Family Physicians. They had me speak at one of their conferences recently in 2018. And I've modified this as I've gone along. I've used this for grand rounds at Wayne State University School of Medicine for their internal medicine department. And I've used it for a lot of residency programs, et cetera. It just gives a good background on what direct primary care is and why I use this model. So my disclosures are that I own and operate a DPC practice. I wrote a book, a couple books about this. So those are my disclosures. So we're going to define DPC and identify some successful DPC practices. So about me, I'm Detroit based here. I'm in Corktown, Detroit, where my office is, where my practice is. Behind me is the beautiful Michigan Central Station. I'm a proud graduate of Wayne State University School of Medicine. I did my residency training at Oakwood in Wayne, which is now Beaumont, Wayne. And because we've done something differently, we've been featured on a lot of news outlets. And I was able to do a TED Talk. And this is my ethos. This is why I do what I do. I'm here because I believe that healthcare should be affordable and accessible. And that's everything I do kind of drives towards that central mission. Here I am at that TED Talk. We talked about the book. This is a really short one. It's about 12,000 words. Take you about an hour to read it, and really describes in greater detail. So if you like what you see here, you can get a further look into this process via this book on Amazon. I price it really low. It's like $4 to the ebook. So if you want to pick it up, that's tremendous. And we built a successful business around taking care of people in a humanistic way out of our office here in Detroit. And because of that, I was named the Entrepreneur of the Year in 2018 via the Detroit Vanguard Awards, which was tremendous. And after I wrote the book, I was invited to the White House by the Health and Human Services Secretary, Alex Azar, which again was a tremendous honor. And I was featured on a couple local Detroit programs about the book. We won a pitch competition in Detroit as well to help spread the word and help people understand this model. And then we opened, I started in this really small one-room office. And because of our growth, we opened this larger office here in Detroit, 1,700 square feet. And we had the mayor come out. I'm with my practice partner, Dr. Raquel Orlick, and our medical assistant, Chris Lake, among some other wonderful people. This is where we're at in Corktown. So what we're going to talk about today is like the current state of healthcare in America and why it's really fundamentally broken. And let's talk about it from like the doctor perspective, because you're doctors, you're medical students, soon to be doctors. 54% of doctors say that they're burned out. And the analogy I use here is that if half of all the light bulbs in your house went out, you wouldn't say, oh man, I have like 25 really bad light bulbs. I need to replace all of them, or they need to go do more yoga and meditate more. No, you'd say like, oh, there's something wrong with my power grid. There's something wrong with the wiring in the house. There's something wrong with the system. And then you'd go about addressing that system. You call an electrician. They'd look at your electrical panel. They'd fix the wiring, maybe replace some old wires in your house. But in medicine, we've done the exact opposite. 54% of our doctors are burned out, and we're telling the individual doctors, hey, there's something wrong with you, the doctor. It's not the system's problem. It's your problem. You need to meditate. You need to go on a wellness retreat. You need to relax a little bit. And by the way, you need to see more patients. And doctors are really feeling that stress acutely of seeing too many patients. And 59% of doctors would not recommend a career in medicine to their kids. And so another problem in medicine is the wait time. So on average, it takes patients about 24 days to get in for an appointment with their doctor. So 24 days is the average. And even when they get to see the doctor, they're waiting maybe 30 minutes to an hour in the waiting room before actually getting in to see their physician. And that's the average wait time across the United States. In Boston, it's up to 109 days to get in to see the primary care doctor. Another really significant challenge in the healthcare system is just the number of patients each doctor has to see. I don't know if you know, but the average family physician has a panel size of 2,400 patients. And on average, you have to see 1% of your panel each day. So that works out to be about 24 patient visits each day. And so a lot of doctors end up seeing 20, 25, 30, even 35 patients every day. And it leads to a sense of burnout, the sense of fatigue, and it leads to the detriment of our patients, meaning that only 50% of the routine, chronic, preventive care is offered to our patients. So only half the time doctors have enough time to take care of mammograms, colonoscopy orders, diet counseling, exercise counseling, refilling medication. So 50% of things get missed in our current system because the volume is just so high. On top of that, as a physician, let's say you are seeing on average 24 patients a day, which is average for a family doc or a general internal medicine doctor. That means you're spending 20 minutes with each patient, but you're not really spending that 20 minutes with the patient. You're spending maybe 10 or 12 minutes documenting the encounter and 8 or 10 minutes actually face-to-face with the patient. This is what's really frustrating, is we built these electronic medical records to more or less take care of the insurance companies. We're spending a lot of time taking care of the insurance company by documenting the encounter appropriately. And that's because we doctors typically get paid by insurance companies. And a lot of what we do in medicine is to justify that payment from that third-party vendor. And we don't spend a lot of time focusing on helping our patients the way we would like to treat our patients. Instead, we play these games around billing and coding to get reimbursement. So there's a recent survey that showed doctors are spending more than half, sometimes even 2/3 of their time on the EMR. And that means they spend less than half, or about 1/3 of their time, taking care of patients face-to-face, which I think is the biggest tragedy of all. When you combine all of these factors in the fee-for-service system, it can feel like you're trying to catch sand, where each grain of sand represents the concern of your patient. Maybe a sore throat, maybe somebody's chest pain, or maybe somebody's hemoglobin A1C that's out of control. And it feels like all these concerns are slowly slipping through your fingers or rapidly slipping through your fingers because you just don't have the time to address all of those concerns. You can't keep up with the volume. So I discovered this concept of Ikeguy, and I realized that a lot of doctors end up within this sphere right here, where they're good at what they do. They're competent physicians. They're sometimes excellent physicians. They can definitely get paid for what they do by billing and coding and making a living, seeing a lot of patients. And they're doing what the world needs. There's not a lot of primary care doctors out there. There's fewer and fewer primary care doctors relative to specialists. And the world needs more great primary care physicians. However, a lot of doctors who are in the rat race of seeing 20 to 30, sometimes 40 patients a day, they're not really doing what they love because they're sacrificing individual patient care and time spent with patients for volume. And more volume leads to greater reimbursement. And it's this perverse incentive that pushes people to this sector right here, where they're feeling comfortable because of their income and doing something they're good at and satisfying a need, but they might be feeling empty. And I know from personal experience during my residency, that's exactly how I felt. I felt like that every day. I felt empty because I knew I wasn't doing a good job for my patients. I was just running from room to room. And that was having like 25 minutes and sometimes 30 minutes per patient. It just wasn't enough time, especially with how clunky the EMR was. Anyways, so direct primary care is this simple way of delivering healthcare to my patients, to our patients, to our communities. And it sounds really simple because it is. I give healthcare to my patients and they pay me money for it in the form of a monthly membership. A lot of my patients pay me $50 a month is our starting rate. It's actually $49. Kids pay $10 a month. Older adults pay $69 a month. So my patients pay me money and I give them excellent healthcare service. And sometimes I'll schedule 1 hour appointment. Oftentimes my appointments with my patients will be an hour, 45 minutes, or 30 minutes. I don't see patients in less time than 30 minutes unless they just need a quick flu shot or they're on a busy schedule and they only have 5 minutes. Then I'll accommodate that. But most of the time I'm blocking out 30 minutes to fully address the concerns of my patients. I'm not just one crazy dude doing this in Detroit. There are a lot of other doctors doing this across the country. When I first started, there were about 380 doctors doing this in the United States. Now there's about 1,300 doctors doing this across the United States. In just about every state, there's not as many in like North Dakota or South Dakota because the population density just isn't there. But virtually every single other state has a DPC doctor. And what I tell people is, if you can afford a monthly cell phone bill, if you're paying $70, $80, $90 a month for your cell phone, you can afford $50 a month for excellent health care services. And then as a family, if you can afford a cable bill, if you can afford, let's say $120, $130 a month for a cable for your family of four, you can afford a membership for health care for your family, right? So, that's the kind of pitch that I give it. A lot of practices fall in this $50 to $100 a month. That's where our practice falls. I think that's where most successful practices price their model at. So defining DPC, we charge a periodic fee. That's a monthly membership. We don't bill on a fee-for-service basis. And some doctors will charge a per visit fee, like $5 or $10 to discourage people from coming in too much. We don't do that. People just pay the monthly membership. But if you did charge a periodic or per visit fee, it couldn't be any more than your periodic fee. So you could, like if somebody's paying me $49 a month, we can charge them, $55 per visit. That just wouldn't fly. But we don't do that. So the big overarching theme is that I want to give my patients a ton of value for their healthcare dollar. So you think value, not volume. In your typical fee-for-service system, you make money on volume. And then the other thing is I'm trying to simplify the healthcare experience for my patients. A lot of patients are looking at the healthcare system like this. It's a confusing mess of middlemen who inflate the cost of their care, all while giving them zero value. You know, for me, the doctor, I'm simplifying this whole healthcare experience. I'm giving the care directly to my patient, thus direct primary care, and then I'm organizing services for them, like meds, labs, imaging, etc., so that their care is more seamless and it's more understandable and it's less confusing, right? And so my patients really appreciate that I'm able to organize meds, imaging, lab services, specialty consults. And then the other big benefit of having a membership at our practice is the assurance that I give to my patients. It's not insurance, but I do give my parents assurance that I'm there for them, that I'm going to listen to them, that I'm going to understand who they are as a person and cater to their individual needs. So if you don't know, when a patient pays into the insurance system takes about 40 cents of that dollar in overhead and all that kind of stuff. The hospital or clinic that you run has generally a 50% overhead, sometimes 60%, sometimes higher. The average family medicine office in the United States has a 60% overhead, meaning for every dollar in revenue that they take in, they're paying 60 cents on rent or lease or staffing or billing or coding or EMR, all those expenses. So the doctor's left with 30 cents. So in a real world example, if you are billed, if you, the doctor, bill your patient for 99214, let's say a bronchitis, 99214 is the billing code. Typically those pay out about $130, $140. The insurance company is going to take $50, your overhead's 50%, and then you make $40. So it's like big whoop, right? Well, you got huge student loan debt, and you figure out that the more patients you see, the more money you make. And so you start seeing 25, 30, 35 patients a day, and that's when you really start to burn out and question your decision to become a doctor. And then it's even worse when you're, like the MBA who's running your clinic says, well, Dr. Smith, you don't get a bonus unless you start seeing 30 patients a day, because that's what Dr. X, Y, and Z are seeing. So you should too. And you're only seeing 18 patients a day. And while your patients' diabetes are well controlled, we just need you to see more patients. And so then you get into this like real rat race of seeing as many patients as possible. So in the direct primary care world, we simplify this. We remove all those middlemen, all those barriers between patients and their doctor. We just offer them care and service for their healthcare dollar. So I hope everybody recognizes this. I'll give you 10 seconds to think about it. I hope you all took this when you started, and if not, you'll take it when you graduate, when you get your white coat or something like that. But this is the Hippocratic Oath, and it says primum non nocere, which means first do no harm. And I think we should extend this to mean first do no financial harm, meaning that the number one reason for bankruptcy in the United States is the cost of healthcare. And the people who are really harmed in our country are those people who don't have health insurance or don't have Medicaid. So let's say you're a typical patient of mine. You make $24,000 a year because you're a hairdresser. Well, the cutoff for Medicaid in Michigan is $17,000, meaning if you make $16,000, you're covered by Medicaid. But now that you earned $24,000 by cutting hair, it's $2,000 a month, you're disqualified from Medicaid, but you also don't earn enough money to buy private health insurance, which can be $300, $400, $500 a month, sometimes even $800 a month if you're older, like maybe 60 or 62. You're not yet eligible for Medicare. And so a lot of people end up in this middle ground where they don't make enough to buy private health insurance, but they make too much to qualify for Medicaid. And then let's say that person gets hospitalized, and then they get hit with the full cost of the bill because the prices charged by hospitals are inflated, and then you get an insurance discount, and it leaves a lot of uninsured folks really vulnerable. Anyways, here's our pricing tiers. Again, very affordable for our community, and we give these balanced, this balance of services to our patients who are members. So one of the ways we lower the price of healthcare is by just making our prices transparent and then negotiating with national partners to get the lowest cost labs, meds, imaging. So for labs, where I worked in the past at Oakwood, which is now defunct, so I can use their name, it was $150 for CMP. It was $140 for a lipid panel. It was $98 for CBC. And when you pay cash, it's $6 for a CMP. It's $4 for a CBC. It's $6 for a lipid panel, and so on. So if I need to check an A1C every 6 months or every 3 months for my patient, that's 4 tests in a year. That's $24 a year to better manage your hemoglobin A1C and your diabetes. And that makes a world of a difference for our patients. And these prices hold through a long list of tests. So the big point I'm trying to make is that, health insurance and healthcare are very different things. Health insurance is a financial tool to protect you from bankruptcy, and you should have it. Healthcare is a relationship that you get from meeting with your doctor. This is a relationship that you're going to give to your patients one day. It's a caring, it's a trusting relationship where you can deliver excellent care to your individual patients. That's healthcare. And a lot of times these two things are conflated, but they're really separate entities. So this is Steve Garagiola. He's a reporter at Channel 4 News, the NBC affiliate here in Detroit. And he did a story on our practice. And he actually gave me a list. He was like asking for a friend, this is one of my friends or family members. These are the medications that they buy, and this is the price that they get it for the pharmacy. What would be your price at Plum Health? So we just ran this comparison. You can see that we're saving this patient hundreds of dollars. And what's crazy is this is a monthly cost. So imagine paying this amount of money every month out of pocket versus this amount of money. It's a drastic difference. So we do this for a lot of different meds. If you need metformin, it's 1 cent per pill. So if you're managing your diabetes and you need metformin, it's 30 cents. Same with omeprazole, 3 cents a pill. Simvastatin, manage your cholesterol, 2 cents a pill. Lisinopril, 10 milligrams, is 1 cent a pill, etc. So let's give the example. One of our patients was hospitalized before he met us for a significant abscess. This guy is about 55, 56 years old. He's a truck driver. He earns too much to qualify for Medicaid, but he doesn't make enough to afford private health insurance. So he has high blood pressure and diabetes that are uncontrolled. He went to the hospital for a giant abscess on his hand. He required an incision and drainage, and he was discharged. And the discharge manager saw our story on the news. And so she referred him to us. And so we got all of his medications in-house, and we started taking care of his medical concerns. And we were able to save him hundreds of dollars on his meds. Lisinopril 40 was $2.70 for a 3-month supply. Simvastatin 20 was $4.50 for a 3-month supply. His metoprolol that he needed was $4.30. And his Tresiba and Novolog were free because we get free samples from industry. So we hooked this guy up and saved him a ton of money on his meds. And these syringes, these Tresiba and Novolog, these can be $300 a pen, $200 a pen or so. And so his issue before, the reason his stuff was uncontrolled was because he was in this messy middle. He didn't have insurance. So when he went to the doctor previously, he was charged, $150, $200 for the visit, plus $500 for his labs, plus $200 every time he went to visit the pharmacy to pick up his labs. So basically, if he was going to the doctor 3 months a year and getting labs 3 months a year, that would be $700 per occurrence. So that's $2,800 over 4 occurrences. Plus, if he needs these meds every month, let's just say he's spending maybe $100 a month. So right there, that's $4,000 a year just on that stuff. And that's if he can avoid the hospital completely, right? So he starts at our clinic, he's paying $69 a month. That's about $840 a year. Plus for every 3 months, it's costing him about, I don't know, $12, $13 a month for every 3 months for his meds. And the true transformation here is this guy goes from somebody who is scared to know what his numbers are, is scared to control his diabetes because he is concerned about how much it's going to cost him, to somebody who is actively empowered and writing down his blood sugar numbers every day and proudly bringing them to our office and saying, "Hey doc, my blood sugar was 130 this morning. You know, I'm really happy about this." I'm like, "I'm happy too," because now our system allows people to feel empowered about taking care of themselves. And that's the real victory in all of this. We also can guide people towards lower cost resources. So like, for example, I take care of patients. I'm out at night. I was actually at the Wayne State Gala 150-year celebration. They asked me to give like the history of Detroit. And then around 10 o'clock at night, I got a text, hey doc, can you help a staff member with a bleeding finger? So I drove in about 20, 25 minutes later, and I stopped the bleeding, and I saved this person who's uninsured perhaps $1,000 or $2,000 or $2,500 from going to the ER, where they would incur that cost, and potentially that would bankrupt this person. You know, if they're making $10 an hour at a minimum wage job, that's $1,600 in income a month before taxes, and then they get hit with a $2,000 bill at an emergency department. That's more than their paycheck for the entire month, just in one visit. And this really costs me nothing. I just put some dry sol on her finger. It stopped the bleeding, and she didn't need any stitches. She had really just cut off the tip of her finger, distal to the fingernail. Only saved her a tremendous amount of money and hassle and time. You know, she could have spent 3 hours at the emergency department. And then the other perspective is like, okay, we're giving excellent primary care, so we're putting less strain on our systems, where somebody might be going to the same emergency department with a heart attack or a stroke. And it'd be great if this patient wasn't there, you know, preventing them from getting, you know, the care immediately. The other thing I do is I help my patients by, you know, recommending that they quit smoking. And sometimes I can encourage people by sending a text message. Hey, hope you're doing well with the tobacco cessation. Let me know how it's going. And this kind of immediacy, this kind of personal relationship that I give to patients can help them quit smoking more easily. So again, we're helping people by being present and available for them in their hour of greatest need. And then just texting them and then being available for routine appointments, all of that stuff helps. So in summary, there's about 130,000 family doctors, and only about, let's say 1,000, 1,500 are doing DPC. In regular fee-for-service medicine, you have to have about 2,400 patients. In DPC, we cap at about 500 patients. So personally, I have 500 patients, 480. I see about 1% of my panel each day. So each day I spend about 3 to 5 hours doing patient care. And then I have 3 to 5 hours each day to follow up, send people text messages, take phone calls, call meds into the pharmacy, or do stuff like this where I'm teaching medical students or helping in the community in some other way. Cost per visit depends on insurance plan. Sometimes it's a $50 copay. Here it's free with the monthly membership. Usually our visits are about an hour. We're paid based on our membership fees. You can't use your insurance in our system. We often save people 50 to 90% on meds, labs, and imaging services. So just a quick rundown. Dr. Chad Savage over in Brighton is doing this. He's an internal medicine doctor. He's partnered with Dr. Cook. Also, I think she's Med Peds. Dr. Ahmad is Med Peds. She's over in Grand Rapids. Dr. Hellman's a family doctor. He's up in Rochester area. Dr. Schumacher, he's up in northern Indiana. One of my mentors, Dr. Clint Flanigan's over in Colorado. And the diversity of the doctors doing this model in terms of geography, age, race, gender, specialization is growing as time goes on. So I think that's where I'm going to leave it. There's a ton more we could talk about, but for the purposes of this conversation, I'm going to leave it here and take any questions that you might have.
So I have a question. When there was an individual mandate, and I'm assuming people that go to you don't actually have health insurance, so did they just pay that fee for not like subscribing to a health insurance policy?
Sure, I think that's a fantastic question. First of all, the individual mandate is no longer in place. Second, the majority of my patients have some form of health insurance. I unequivocally recommend that people buy a health insurance plan that they're comfortable with. However, once people are with me for 3, 6, 9 months, a year, they figure out how much they can get from my office, and they can get like 90% of their healthcare needs from our office. And then they look at their insurance plan, they're like, well, I really only need this if I get hospitalized, right? And then they're like, how often do I get hospitalized? I haven't been to the hospital in the last 10 years. So let me buy a low cost, low premium, high deductible plan. And my deductible is like $6,800. So I'll put that into a savings account and I'll pay Dr. Thomas for my primary care. So to answer your question directly, yes, people who are uninsured, which really sucks. Let's say you're making $24,000 a year, and then the government tacks on a $600, $800 health insurance fee because you can't afford insurance. I think that's crap, but whatever. Yes, people were forced to pay that, because they sometimes through no fault of their own. Let's say you work at a restaurant and you make $12 an hour. How many restaurants offer health insurance plans? Not that many. It's really rare because as a part of the ACA, only companies with 50 or more employees are mandated to offer health insurance. If you have 50 or fewer full-time equivalents, you're not mandated to buy health insurance. And then companies know that and they get around it. So they'll open one restaurant under one LLC and they'll employ 40 people. And then they'll open a second restaurant with another LLC and they'll employ 40 people. They'll open another, it's just, these government mandates don't help people get better health care. I guess that's the point I'm trying to make.
Dr. Thomas, what do you, I see what you're doing there is it's like it seems to me is like the next step in healthcare and trying to get around, I guess, sort of the bureaucracy that we have to get around as a doctor. I'm wondering to what extent, let's see, what are the biggest regulations that you find right now in Detroit pushing people away from universally just coming in and doing a service like yours as opposed to staying with the typical family physician?
Yeah, I think, okay, so the biggest barriers to adoption of direct primary care are probably just education. People think that having and using insurance is the only way to access healthcare. And for a long time, that's been true. Direct primary care has really only been around nationally for about 10 years. Since maybe 2010, it's been officially called direct primary care. And there's actually a line item in the ACA that describes and defines direct primary care. And then in the Detroit market, we started in 2016. We were the second practice in Michigan to do direct primary care. And so a lot of my time, effort, and energy is spent educating people about what direct primary care is and is not. And that's like a very big uphill battle. So that's the biggest barrier to adoption of direct primary care. There are no, let's say, locally, there's no legislation or problems in the Michigan or Detroit market that prevent people from using DPC. It's just more of like a national legislation, the Affordable Care Act, and then also just the history of our country around how people are compensated. Did you know that health insurance was really born out of World War II? There was a wage freeze placed on companies. You couldn't pay your employees anymore. So in order to compete for better talent, companies started offering competitive benefit packages, including health insurance, retirement accounts, et cetera, et cetera. But health insurance was the big one. And so health insurance hasn't always been tied to your health care, to your job. And once we've, tied those two things together, health insurance and your job, it makes a lot of things more difficult in our economy. It's harder to be an entrepreneur because you have to leave a job where you have an income and your health insurance to start maybe something you'd love to create, like a store or an independent practice or whatever. And that's another barrier to people getting access to direct primary care is, we doctors, we have a huge debt burden. It's scary, it's risky to start your own direct primary care practice. And so you have to leave a paycheck, you have to leave health insurance to go out on your own, your malpractice insurance through your employer, all that stuff, you have to leave that and then create it on your own through your own company. And that's a difficult process. It's a huge barrier for doctors to adopt this model and to leave, the health insurance model, the fee-for-service model.
Hi, Dr. Thomas. I have a question. Thank you so much
Sure.
for talking to us, by the way.
Oh, you're welcome.
I have two questions. You mentioned malpractice insurance, and so I was just wondering what kind of malpractice insurance you had and feel like you need to carry. And then if that changes, like, because you are a direct primary physician, if I'm interested in OB-GYN, and so like if I were to open, something like this, would I need more because maybe I'm doing more procedures, or how that changes based on what procedures you do. And then also, how do you get your patients? You mentioned like you have to do a lot of patient education, but how do you get patients? How did you start your practice in getting patients to meet a minimum amount of patients to like be successful?
Sure. Those are all fantastic questions. So let's start with let's just talk about costs of running a business. Your biggest costs when you run a business are your square footage, like your lease or if you own a building, that's expensive. And then your second cost is staffing. Or actually right now, the cost of our staffing is high because I employ 2 doctors and a medical assistant. And then myself, I do pay myself. And then we have our lease, which is about $2,800 a month. Okay, then our EMR is about $300 per doctor. So we have 3 doctors, so it's $900 a month for our EMR. And then malpractice insurance. Malpractice insurance is about $500 a month per doctor. So we have 3 doctors, so it's about $1,500. Yeah, I did that right. $500 a month per doctor. So $1,500 per month for our clinic. Yeah, it's about $6,000 a year to have malpractice insurance. And that's doing outpatient only, no OB. It would be higher if OB was considered. Our malpractice insurance is actually a little bit lower than a typical doctor in Detroit because we talked to them. We told them, hey, we have fewer patients than the typical primary care doctor, so we get a slight discount there. It is higher though than in the state of Michigan. Our malpractice insurance is really high in Detroit relative to Michigan because Detroit and Wayne County it's a more litigious community. So more people are sued in the city of Detroit than in other communities, and for reasons, that's a whole nother conversation. But that's a part of why our malpractice insurance is what it is. And we have occurrence. So basically anytime there's an occurrence, our insurance kicks in, and we have tail coverage and all that kind of stuff. All right. And then help me out with your second question there. Oh, how do I get patients? Yeah. So basically there's a couple different ways that I get patients. And one of those is through search engine optimization. The other way is through social media. So you could try this at home. You Google best primary care doctor Detroit, or best family medicine doctor Detroit, or doctor accepting new patients in Detroit. And if you do that, hopefully you find us as your #1 hit. And when you do, you'll see that we have 73 5-star reviews on Google and all that kind of stuff. I really go into great detail on this in my book. Hold on one second, forgive me. Yeah, this is the book, Startup DPC. And I do talk a lot about branding and marketing in this book. I give doctors, exactly how I do this. So chapter 13, page 255, marketing your direct primary care practice, and then earning media for your direct primary care practice. That's chapter 14. And so I interact with a lot of journalists so that they can understand what we're doing and hopefully write some stories about us. So we've had some success. I've been on TV. We're on the front page of the Free Press. We do radio. I've been on WDET, which is the NPR affiliate here in Detroit. We're actually going to be on a national show called Startup. It's called, the show is called Startup on PBS, and we're going to be featured in one of their episodes. That's going to be coming up in a couple of months here. I'm pretty excited about that. If you follow our blog on plumhealthdpc.com, I'll be writing about that. Or I put up my Instagram and our books in the chat here today. So if you want to follow along on my Instagram, I'll post about when we'll be on that show and the other fun stuff we're doing here at the office. And so that's basically how we attract patients. We consistently communicate. I have an email list. I email all of our people on our email list every month or so, tell them what we're doing, how we're different, how we're lowering the cost of care, and how we're making healthcare affordable and accessible.
That's really cool. I can see that patient education would be really big, because people are kind of set in there, that insurance is the way to go. But once you start explaining, how much money you can save, and also just the attractiveness of being able to contact your doctor and get a response and come in, when you feel like you want to, or when it's more convenient for you, because so often you have to wait so long to get in contact with your doctor or things like that. It's really cool.
Yeah, we guarantee a same day or next day appointment for all of our patients. I always have a couple extra minutes or hours in my day where I can fit somebody in. And so if you text me in the morning, I can guarantee I'll see you at least by 5 p.m. And if you text me in the afternoon, I'll see you as soon as I can. And if I have to, I'll stay after. I'll see you at 5 o'clock. Our office usually closes at 5, but I'll stay here for you just to make sure that you get the care that you need.
Hi, Dr. Thomas. I have a quick question. Thanks for talking to us today. I was just wondering how your referrals to other allied health professionals work, especially people like dietitians who patients might see chronic conditions and over, not just a one-time referral. And then I'm also wondering if you do home visits or if that's something that some DPC providers would do.
Yeah. So yes, I've collected a list of a lot of different doctors, nutritionists, behavioral health professionals, etc. And I send patients to those, nutritionists, dietitians, etc. And, if you're paying $50, $75, $100 per session, that's something you can do. If you want to get that counseling from me, I'm more than happy to meet up with you every week or every other week or every month to make sure that you're on the right path in terms of controlling your weight or diabetes. I do a ton of diet counseling for my patients. And that's just part of my practice. And then I do leverage a couple other tools. There's a tool called Rubicon MD, where I can write up a patient's history and send it to a specialist, a board certified specialist. We just did that for urology. One of our patients had a feeling of retention. And so we were just talking through what the best imaging or best test would be to perform, and the most likely diagnosis. And we settled on getting a bladder scan, looking for a post-voidal residual, and then maybe treating with like a anticholinergic, something like tolterodine or Detrol or something like that to help them manage that concern. So, and then there's specialists locally. There's a dermatologist in Midtown, Dr. Carter Snell. She has cash prices. I asked her, hey, what are your cash prices? There's a lot of people in Detroit who are uninsured or underinsured. So, it's $138 to see a dermatologist in Detroit, $138. So some people are paying $700, $500, $600 a month for health insurance that they never use. You could drop down your coverage level and purchase health care on the free market at a more affordable cost.
What happens if one of your patients needs surgery?
Yeah, that's a great question. That's definitely happened in our office before where somebody needs surgery. So I've called Henry Ford Hospital and I've requested pricing. It's only $3,800 to have your gallbladder removed at Henry Ford Hospital here in town. And that took me 20 minutes to find out. I just called their billing department, called their surgery department, and that's what they could do it for. The average cost of health insurance for a family is like $14,000 a year. It's like, oh boy.
So
And then there's another one. There's what's it called? Surgery Center of Oklahoma. You can go to that website and you can see all of their prices listed on their webpage.
So Dr. Thomas, I'm wondering to what extent you see the possibility in the future of perhaps recruiting other care specialists, whether it is dietitians or maybe physios or osteopaths or other people of the sort, and seeing how that can be factored into maybe the monthly price that you're currently giving, and just have that encompassing service sort of under your clinic.
Sure. I just am a big believer in the free market. And so it's like, for me, I know exactly what we do at our clinic really well. And we deliver an amazing patient experience for our patients. We deliver excellent primary care services. And that's our wheelhouse. That's all I want to do, because that's where we're the most successful. And we're completely different than any other primary care service in Detroit. And that's why people love us. We're not trying to be something we're not. We're not trying to be, PCMH 2.0, patient-centered medical home. We don't want to be that. We don't want to add in all these services, because not everybody's going to need a dietitian. Everybody that comes to our door needs excellent primary care, and that's what we offer. But of the few patients that we're going to refer out to dietitian, maybe we refer 2 people to a dietitian every year. I'm not trying to hire a dietitian for 2 people, and they're going to have a great experience seeing that outside dietitian that they connect with, right? Same with behavioral therapy. It's like maybe 20 of our patients need a behavioral therapist, but people need behavioral therapy for different reasons. Some people have trauma from relationships. Some people have experienced rape or witnessed a murder, have PTSD. Some people have family discord or are suffering through a job loss. And so different therapists are going to specialize in different areas. And so I'd much rather send somebody to the person that can help them the most. So I have a list of like 20 therapists, and this person is concerned about trauma, relationship trauma, or abuse. I'm going to send them to Kristen because that's her specialty. Or, I'm going to send, if they have something with PTSD, I'm going to send them to this other therapist because that's their wheelhouse. So basically I spend a lot of my time figuring out the best resources for my patients and then connecting my patients with those resources.
Awesome. Thank you. I agree with you. The free market's very healthy for development of really good healthcare. So
thanks.
Hi, Dr. Thomas. I just wanted to ask, I don't know if you had this problem, but how would you balance, so for a medical student who's graduating, going into residency, or maybe finishing up residency, how would you balance, I guess, what you're charging your patients for the care that you're providing with any loans or like debt that you would have to pay back?
Sure. I'm really transparent about this. I wrote about this in my book as well. I graduated from Wayne State School of Medicine with $170,000 in student loan debt. I graduated in 2013, and that was the average debt load for a 2013 graduate. I think in 2019, that went up to $195,000 was the average debt load for a graduating medical student. So I'm sure a lot of you are facing somewhere in the $100,000 to maybe even $400,000 in student loan debt. if you're coming out of school. So here's what I did. I paid it off aggressively. I consistently live below my means. I enjoy my life. I do a lot of excellent, fun stuff, travel a lot. But I don't have a big house. I have a modest house. I have a modest car. I, don't spend on frivolous stuff. I just have what I need, and I'm kind of living out my passion that way. That, kind of frugality in some areas of my life has allowed me to live richly in other areas in terms of like pursuing my passion. So I firmly believe that you can afford anything you want. It's just kind of like, what are you willing to sacrifice to afford, the things that you want? This is kind of like another philosophical topic of conversation. But pragmatically, if you have under $200,000 in student loans, that means your monthly payment on a 30-year could be as low as like $1,000 a month, depending on your interest rate. So when you graduate, you can consolidate your loans into something like SoFi and get a lower interest rate. For me, I did a straight 10-year repayment plan where I aggressively paid off my loans, and it was $2,000 a month. It was actually $1,957 monthly to pay off my $170,000. And so what I did is I started moonlighting as soon as I could in residency and used any extra money to pay down my student loans and lived off my base salary of like $3,000 a month from my residency. Then when I started earning more money after graduation, I, by the way, didn't sign anywhere. I just worked at an urgent care 2 days a week and then spent the rest of my time growing Plum Health. I aggressively used any extra money to pay down my loans. I paid off my student loans last year. It felt amazing. So 6 years after graduation, doing something non-traditional where I had a lower income than a typical physician, I was able to pay off my loans in 6 years. Pragmatically, if you have $400,000 in student loan debt, I would say take an employed position for 2 years, pay down your loans aggressively. You could probably get down to $200,000 or $100,000 by the time that 2-year period is over if you live modestly, and then do what you're passionate about. If it's starting a DPC practice or doing something different, it's all possible.
Okay, thank you.
Oh, you're welcome.
I think we're nearing the end here. Maybe time for one more question?
All right, gang. Thank you so much for having me. I think I'm going to call it. I really appreciate your time and attention and great questions. Again, if you want to read more about me, I've got a couple books out there in the ether. We got a ton of information on our blog at plumhealthdpc.com. And then, follow me on Instagram. It goes a long way. And then, a final ask that I'll give you is like, I do a lot of these, and it really helps if you guys individually post on social media about our practice or about direct primary care to spread the word, because as you heard, one of my biggest barriers is educating people. So if you even post our website or post our blog post or share one of our Facebook posts or Instagram posts or tweets or whatever, it goes a long way to getting the word out there about direct primary care, about our practice. So I would really appreciate that if you guys could do that for me.
Do you guys have a LinkedIn by any chance?
I am on LinkedIn.
Does Plum Health as a organization have LinkedIn?
Yeah, for sure.
Okay, so awesome.
I'll put that in the chat here. Let me see if I can find it. Plum Health LinkedIn. That's giving me a hard time here.
Yeah, as long as I can find it, right?
Yeah, if you go to my page, the link, my Paul Thomas on LinkedIn, you can click through and see the company that I work for is Plum Health DPC, and then you can click through that company and find it.
Awesome.
Okay, thanks so much, Dr. Thomas. If you guys want to know more information about BRI as well, feel free to reach out to any one of us, myself, Cassandra, Kennedy, Caleb, or Mindy. Otherwise, stay tuned for the next BRI events, and really looking forward to it. Again, thank you, Dr. Thomas. Great talk.
You're welcome, guys. Have a great day.
Thank you.
Thank you.
You're welcome. See ya.
We have to get off the call. Oh, is there anything we needed to talk about? Oh, Tyler left.
I think Tyler's gone already.
Oh, okay.
Yeah.
Like, cool.
So I think we're good.
Bye, guys.
See you guys.